sees patients in the clinic here in Saratoga at the North Platte Valley Hospital once a month, right? And Stephanie Ponish, and Stephanie works for an agency. She's going to tell you all about that. She's a hospice nurse working in our community to help families, patients, and doctors, and will tell us about her agency and what she does for us all. And Susan Dyer is a grief counselor, and that's only one of the hats she wears, but she does a lot for our community and has several groups of people over the years here, and I think before that. And she has the gift of caring, listening, supporting families and people dealing with grief. So welcome all, ladies, and it's all up to you now.
Thank you, Leslie.
Bye-bye.
Thank you. Warm welcome. Thank you, everyone, for being here. These are such important conversations. And I don't know if everyone knows the topic of today's conversation or if you were tricked into coming here. But hopefully this can be a start of more conversations and culture change. So thank you so much, Leslie, for the invitation. Like she said, I'm Dr. Emma Bjore, and I've been a geriatrician in Ivinson for 8 years, and then almost 8 years, and then I've been up here for almost 7 years. Coming every month. I started out in the nursing home and in the clinic, and now I am really just in the clinic up here once a month. So it's been an amazing opportunity to be able to engage in even more rural community. And as many of you have been around this area for that amount of time and more, you've seen a lot of changes in the healthcare community. So I hope to continue to be just a consistent presence in the community. So I appreciate this opportunity to be able to engage in this way. So I just want to talk a little bit about maybe my background in healthy aging and death and dying, and then I'll turn it over to my colleagues to tell a little bit about their experience and background in this topic, and then we can open it up to conversation. So I grew up in rural North Dakota and did my medical school training up there and residency and fellowship in Denver. So I was very happy to have that training, but also to get out of the city. And I have a little ranch with some horses and donkeys in between Laramie and Cheyenne. So that's just been a blessing to be able to be there. One of my missions as a geriatrician is really to get to know my patients and partner with them and figure out what their goals are in the aging process. And so oftentimes we talk about the last chapter of life in addition to, I start seeing patients when they're around 70. And so oftentimes we're talking about, okay, how do we age healthfully? How do we avoid disability? How do we remain independent? What are your priorities, and how can we support that? And then we also talk about that very last chapter of life. And so oftentimes people say, well, I want a good death. And then we try to explore, what does that mean? But really what we're trying to support is how to have a good life until the very end. And so I hope that that's something everyone is thinking about. Doesn't matter what your age is or your health conditions. That's a sacred part of life, and we want to make sure that we're living well, whatever that means to us, until the very end. And so I brought some presents for the first 5 participants. I don't know if anyone has read Atul Gawande's Being Mortal, but it's an absolute must read. It came out, I think, 10 years ago now. New York Times bestseller. Atul Gawande is a surgeon and a fantastic writer, and has done so much writing on these topics. And so I'll read a little excerpt from the epilogue just real quick, and then I'll turn it over to my colleagues. Actually, I'll wait on this. I'll read this after these lovely ladies introduce themselves. Keep you on the edge of your seat.
Well, hello. I'm Stephanie. I live here in Saratoga. Most of my career has been working in nursing homes across the U.S. I've worked in West Virginia. I've worked in Virginia, and kind of moved my way to get closer here to where my parents are from. So I'm here in Wyoming now. I do home health and hospice. So a lot of people don't realize we are here. We actually cover all of Carbon County. Gets busy at times, but we go from Hanna, we go to Encampment, we do Saratoga, we're also in Rollins. And one of our main focuses is keeping people at home longer, being support for the patients and the families in the home, because nobody wants to go to a nursing home. I mean, that's not anybody's goal, as I'm sure they're talking about end-of-life choices. So what we try to do is keep people in the home longer with that support they need. We also offer hospice services. And so that's at the end of life, death and dying process. And we're there for support for them. And we try to teach them how to embrace death and dying, because it's a natural part of every one of our lives that we're going to be exposed to. So that's one of my goals in home health and hospice, is to help people understand the process and to embrace it and to make it easier and to transition. I don't know what else to say. I'm not the best at these open forums.
Can I ask you, who's we? Are you with an
I'm with
agency
Best
or-
Home Health and Hospice, yes. I'm an RN, and I cover the Carbon County area.
But are you independent? Are you with an agency or with?
I'm with an agency, Best Home Health and Hospice.
Oh,
That's
okay,
what it's called. So,
Okay.
and they're out of Evanston. I have some brochures at the end. You guys are welcome to grab, and you can learn
Okay,
more about our
okay,
company
that's what I
and kind of where our offices are, because we're all over. But yeah, a lot of opportunity for home health and hospice in the area. So.
What criteria do we need in order to get you to help us in our situation?
Biggest criteria, and there's two different criteria. So home health has a criteria and hospice has a criteria. Home health, the biggest thing is you have to be homebound if you're pulling from Medicare, because Medicare usually covers home health 100%, as well as they cover hospice 100%. But some insurance policies don't quite cover 100%, but that's where your secondary will step up. So the biggest thing is you have to be homebound. You cannot be driving. It means you have to have assistance from somebody else in order to leave the house. So that's how that works. Hospice is a little bit different. You just have to have certain diagnoses for end-of-life diagnoses. And there's like a whole list of them you can have, from COPD to chronic kidney disease. So that's kind of the criteria for hospice.
So we have to inform you that we need your service, and then you evaluate?
Nope, you just discuss it with your physician. So whether it be Dr. Bjore, or it could be Jolena, it could be any physician.
What if we don't have anybody?
You do need someone. You do need a referral. So Medicare will require a referral from a physician, and then the physician is required to continue to certify and oversee the care that's being provided by home health. So I don't know if the urgent care providers are willing to step into that kind of primary care role or something like that. But you will need to establish with someone for primary care to get a referral for home health.
Well, in our dire situation that we have right now, where do you suggest we go? I mean, you're here once a month, and Jolene is, she's quitting the hospital, and so where do we go?
There's Dr. Lassard at the clinic, at the county clinic across the grocery store.
Is she a physician or?
She is a physician, and she's been here only about a year, but she moved here because of her husband's work, and she loves it here, is very happy here. She's she has a lot of background in nursing home work and hospice work. So, and I really like her. Pat really likes her. I'd give her a try.
Yeah, that's great. And I know the hospital is recruiting.
They have hired someone.
Terrific. So hopefully more to come.
I've heard that there are doulas now that can go into the home and just stay with the family. and I'm not sure if that's in Wyoming. Could you comment on that?
Well, something, we don't come and live with the families, we're just there for support. So like, and your Medicare will only pay for so many visits, so we have to stay within those guidelines. So it depends on what you need. Everybody's different, everybody's individualized in their plan of care. So some people might need physical therapy, and in some instances we can bring that into the home too, so they're not having to drive back and forth to therapy. But in any of these, hospice, home health, we don't come live. We do a lot of education. I wish we could come live with some people and help them through the process, but it's just not realistic. So it comes with a lot of education from myself, from your doctors, from your home health aides that also come in. But yeah, we can't live with people.
So if a doula was coming in, that would probably be a private enterprise between the family and the doula.
Yes, so there are some private people that will do that. Of course, there's private pay and insurances like Medicare, Medicaid. They won't cover that cost of those private pay people. But yeah, there are people that will come and live with people and take care of them.
So
And that's
what kind of
wonderful.
help do you have? RNs, LPNs?
I have RNs, LPNs, I have CNAs. So that's mainly what the home health team is. And we also, in some areas, we have physical therapy also to help people get better, because the goal of home health is for people to come home from the hospital, continue what they were doing in the hospital health-wise, so focusing on that physical therapy to get strong so that they can be able to be independent at home and they don't need help. So sometimes we come in just for a short term, 2 months at a time, and we get them stronger and then we step back out. Because that is the goal, we want them to improve.
Sorry to interrupt, and you're giving a bunch of great stuff, Stephanie, but Susan has not been able to introduce herself yet, because all the questions is what she does.
Yes,
So if we
let's
could do
go
that,
to
that'd be great.
Susan.
Thank you, Josh. I'm Susan Dyer. I've been living in Saratoga now for about 15 years. I'm an ordained clergy person with the Episcopal Church, and when we first moved here, I looked around and I thought, boy, what does this community need that is not available? And everybody was telling me grief work, help with grief classes and stuff. Well, in my background in Colorado, I had been a hospice chaplain for Heartland Hospice, and I had also been a hospital chaplain. So it was like, even though I had told my bishop when I was first ordained, I do not want to work with dying people. Never tell God what you don't want to do. So I started a grief group here probably in 2011, 2012. But in order to actually start that, I went to a friend of mine who was in Colorado, who was a therapist in Colorado. And I knew that she did a lot of grief work. And she spent an hour, not an hour, she spent a day with me. And finally, when the day was over, she said, okay, I'll give you my program. So she wanted to know, first of all, could I listen? And that's mainly what I do. She had put together a wonderful program using many, many resources, a lot from hospice. But through the years as she had done her work, people had given her poems and recipes and wonderful things. So we started a program here. She told me one thing, because she had lived in Laramie. She said, you'll never have a man in your program. Well, doggone it, she was wrong. And we did probably the second class I did, we had 2 men show up for it. And then because of them, I've had some other men come. Grief has many, many faces. And I think what we really need to realize is that we grieve all the way through our lives. We grieve when our children grow up. We grieve when our children go to college, some of us more than others. Some of us are happy, but we grieve when our own parents pass away. We grieve when our pets are gone. We grieve during times of divorce. We grieve, but we don't put it all together that we have grieved. And when people finally get to the point of wanting to come to a grief group, the first thing we talk about is how many griefs have you gone through in your life? Because you probably never did sit down and actually work through those grieving times. The groups that I put on here are free. I just don't think that anyone should have to pay to talk. And I never want to be paid to listen. That's a fun thing. But I try to at least have one group a year. We usually start toward the middle or end of August to give people the tools they need to get through the holiday season, finishing up by Thanksgiving through Christmas. That's kind of my reason that I started this, and I have papers here that you can look at, or I'd be happy to answer questions. But there was a person who attended the last group I did, and I asked her if she could talk for me if I couldn't get here today. I want you to know I drove all the way from Colorado in the wind yesterday.
Thank you.
Oh, that wind. Anyway, she addresses this letter to you all. Dear Tuesday Talkers, I'm sorry to have missed this program, but on the off chance that Susan was unable to get to Saratoga, I promised her that I would comment on the benefits of a grief support group from my viewpoint. I lost my husband of 46 years this past fall. I knew I had tremendous support from family and friends. However, I knew I needed to seek support from someone that was neutral to my emotions, experiences, fears, and heartaches. A grief support group offered this for me. I was able to share all ranges of emotions without judgment. I was especially lucky as our support group had a specific curriculum that provided carefully designed readings and questions for participants. Our group was small, and this allowed each of us to become new supporters of each other. My daughter and grandson were able to attend grief group as well, and I know we are all much further along in dealing with our grief than if we had not been attending this group. Do not underestimate yourself, nor hesitate to seek out emotional help through a grief support group. A grief support group will help you move through your grief, accept the grieving process, and start to heal. I'm grateful and thankful to have had the opportunity to participate in this grief support group. She says that a lot. And as a matter of fact, this support group is still going on without me, which is a wonderful goal. The support group lasts from 8 to 10 weeks, depending on the size of the group, because everyone needs a chance to tell their story. Everyone needs to bring pictures of their loved one. Everybody needs a chance to tell you about the funeral service or the burial of the ashes. Everybody needs a chance to talk. So the larger the group is, the longer it takes. But and then to be small enough this time to allow children to come was I'd never done it before. It was delightful. It was wonderful to adapt the program that the little children were able to be a part of it. So.
Well, thank you for that background, Susan, and all of your amazing work in the community. That's wonderful. All right, let's move on to our reading. Oh, she's good. I know you've been on the edge of your seat. So this is Atul Gawande's Being Mortal. And this, I'll just read a couple paragraphs from the epilogue. It says, being mortal is about the struggle to cope with the constraints of our biology, with the limits set by our genes and cells and flesh and bone. Medical science has given us remarkable power to push against these limits, and the potential value of this power was a central reason I became a doctor. But again and again, I have seen the damage we in medicine do as we fail to acknowledge that such power is finite and always will be. We've been wrong in what our job is in medicine. We think our job is to ensure health and survival, but really it is larger than that. It is to enable well-being, and well-being is about the reasons one wishes to be alive. Those reasons matter not just at the end of life, or when debility comes, but all along the way. Whenever serious illness or injury strikes and your body or mind breaks down, the vital questions are the same. What is your understanding of the situation and its potential outcomes? What are your fears and what are your hopes? What are the trade-offs you are willing to make and not make? And what is the course of action that best serves this understanding? So, lots of good questions there. If anyone, if that resonates with anyone or anyone has any thoughts on that, I would love to hear it and give out 5 copies of Being Mortal.
I want a copy, Doctor.
Yes! Do you have any comments about that excerpt or Death and Dying or our
I
aging
get a
process?
glimpse. I have no knowledge of this book. But I think the question about how far to go with care is a big decision making for families, for spouses, and not thinking about it ahead of time can cause heartache beyond belief. Not ever having said, what if you die? What if you're sick? What should we do? And families being able to talk about those things ahead of time is really smart and comforting. And people shy away from it for a lot of reasons. But I'm encouraged to know about the book, and you've all said that it's worth reading. So I want a book.
Yes! Thank you for those comments, Leslie. And I think you're right. Most of us probably didn't grow up in a culture where we were discussing some of the what ifs. And as life changes, we all adjust and pivot. But it is important to have those conversations early. And I always think of it as a gift to your children or your siblings or whoever your support people might be, in that we want them to be equipped with the knowledge of what's important to you and what you're going to want if your health situation were to change. It's going to be a stressful time for them, no matter what. But without those conversations and without them having the power of the knowledge of what you actually want, they're left guessing. And they're left with the weight and the burden of making a decision on their own instead of making a decision on your behalf, knowing what they know about you. So I do also have copies of Ivenson's Advanced Directive, which is good anywhere, and the Wyoming Post form, which we can discuss in more detail if anyone's interested in. But thank you for those comments, Leslie. Does anyone else have any comments? Tammy?
Yeah. Hi, Dr. Bjore. Thank you guys for coming and speaking to this. As the former director of nursing at the hospital, I was not an individual that was really interested in becoming a geriatric nurse. My background in nursing was mostly critical care, life or death situations. And so we ran in, and I ran into the personal aspect of having to cope with going through COVID, where we had a lot of individuals that choices were made for families, friends, loved ones, and leaving that practice after COVID left me quite scarred as a practitioner. And so coming into the nursing home, once again, you're in what I had referred to as the aged population had been a throwaway type of a population. And coming into it as the director of nursing, tackling the geriatric population problems associated with, and there's a plethora of issues that go with aging, coping with aging, and it starts at a much younger age than what our culture even recognizes as issues of geriatric advancement. I just recently retired, and so I'm not quite 65 yet and had the opportunity presented by my mother to retire early so that I could address some of the situations that you guys are talking about currently. And one of the greatest blessings that I've had is to be able to be with her in the present before her age became a dramatic effect in both of our lives. But I think that the issues that we talk about are not, we don't talk about, right? That aging is something where our society has reveled in it and then we discarded it as families have moved away. We don't take care of our aging population. I shouldn't say that because there are some families that really gravitate to facilitating the care of the individual from the time of birth to the time of the grave. And so finding those individuals that revel in that and really celebrate it, that it is a full life, is not just when we're young. It is the entirety of the process. And so I'm really thankful for my mom that she's given me the opportunity to be able to do that. So I'm interested in the book as well. Because I am a believer that we need to celebrate our elder population as I'm entering into that.
You touched on so many great points, Tammy. And you know, being able to have worked with you in the care center and see your growth and development into a nursing professional in a geriatric setting was amazing, because it is quite a shift from a critical care situation to, hey, I'm taking care of people in their homes. And how do we create person-centered care? And you touched on COVID a little bit too, and we could spend a whole hour talking about how we treated our older adults during that time period.
And everybody's been affected by COVID, regardless of your age, you know, and I think that the grief process through COVID hadn't been addressed either.
Yeah.
Anger,
Yeah.
Yeah.
you know, and
Another thing that I have noticed since I lost my husband is that we fear death. We remove ourselves from the situation, and how horrible that really is when you are presented with it and you're not ready. It can be just awful. Now, I was a nurse and I went through death and dying, and I had to use Tammy as the person. And let me tell you, it was an earth-shaking revelation. But I'm glad that I had that experience because when Bill died, I was fine. And I have not had any depression, sorrow. I have a different aspect. My knowledge of death is so different. It's a beautiful solution. And why we don't celebrate death, I don't know. But I have friends that are, Bill's been gone 3 years, my friends had a husband that's been gone for 2 years. And she is a total mess. She has fear and why me? And, you know, I miss him so much and I talk to her and she bawls all the time. I am so happy that I have had the experience with that because I'm not depressed, I'm fine, and I have been, and people will say, well, are you depressed? No, I have never been depressed. I'm so happy that I had years with Bill and I dwell on the positive. And for some people, it's just like, I can't get over it. I can't get over it. How sad.
Yeah, I definitely think everyone has their own process. Thank you so much for sharing your
Well,
story.
and if anybody needs support, that girl right there is awesome, unusual.
Susan, do you want to speak to some of these comments about about death
how
and
you get
grief
through it
and
and how you grieve.
why
Right.
we're so afraid of death.
Everybody does grieve in their own way, and I honor that and respect that. A lot of people say I pre-grieved my husband or my wife or my parents were, and I watched them, and so I anticipated their death for so long that they call it, I pre-grieved. And I'm not 100% sure that anyone really pre-grieves, because the end comes, and you don't say, oh, I'm fine because I knew it was going to happen. It still calls on whatever resources and tools we have at our disposal, whether those are because of the experiences that we've had. I'll tell you that I had probably been doing grief work either through hospice, a hospital, or here for 15 years before my parents died. And I thought I had pre-grieved. And I thought I didn't need. But the last grief group that I went through as a facilitator, I found myself living through the program of grieving that I thought I had already done. So, we all grieve in our own way. For some people, it takes 3 months. For some people, it takes 8 years. And my personal opinion is you're never done. You change the way you live. You change the expectations you have. You find a new reason and a new life. But you never get over the sadness of not having what you had. I don't want to book.
Well, somebody mentioned families living at a great distance from one another. And I have a situation that my brother has spent almost all his life in Hawaii. And he's now 89 years old, and he's not expected to live 1 or 2 more years because he has a chronic disease. So I call him up almost every week. We talk, and he tells me what his latest medical experience is, and he asks me what I've been doing, But what do you suggest a person do when you have a close relative that is so unavailable, basically?
Yeah, that's a great question, because there's so much to long distance caregiving. And I think Hawaii is one of our youngest states, probably for that reason. And so it's so interesting that he is there at 89 without any family.
Well, no, he has a wife.
Okay.
Yeah, she's very tired of taking care of him.
Oh, sure. Yeah. Stephanie, do you have any thoughts on long distance caregiving? I mean, you moved here personally to be closer to your parents.
That's a tough one. You got to tap into whatever resources are there in Hawaii. I'd go to Hawaii for a little bit, but no, that's where you just got to research all the resources in that community, because there's a bunch there, and I'm sure there's some private people that'll come in and help, because caregiver burnout is real. I mean, I see so many families just get burnt out taking care of people, so it's important.
She's burned out,
Yeah, so.
Well, I'm thinking of visiting for a week if they can stand me, be there, because he's still very alert, and I don't know how long that'll last,
Yes.
So I'd rather see him live than have to fly to Hawaii for a funeral, although that might be good too, I don't know.
Well, how lovely that you call him every week and that you're thinking about this trip. I do want to acknowledge your observation that his wife is already tired and might be struggling. And so when you do get there, encourage her to take time for herself.
Oh, yeah.
And to leave and to, go to the beach or the spa or whatever would fill her and rejuvenate her. But it is such a longitudinal process. that you do want to figure out what are those resources,
Yeah.
like Stephanie said, that could create more sustainability.
Well, they're very good about seeking help, but they really won't change anything. Anything.
I've found so many people, they want to take care of that person 100%. And it's too bad because they do need a break. So if I was this lady, I think I'd go to Hawaii maybe every 3 months.
Yeah, that wouldn't be bad.
There you go.
So,
But I do think a lot of people have a strong identity in their caregiving role, and so just to be present and to let her know that you see how much she's doing for your brother, you appreciate her, if anything comes up like, oh, I'm just so tired of cooking, right? Then maybe you can order that, and we can do this remotely now. You can order them meals from
Or DoorDash.
DoorDash. Thank you. I live in the country. There's no DoorDash.
A
DoorDash.
little better than
You can-
some meals on
Yeah,
But another thing we can do, instead of always calling the patient, call the caregiver. And they are wonderful. I mean, they appreciate it because everybody forgets about that caregiver.
I'll try to do that more. As it is, when I dial up her phone, she, after 1 or 2 sentences, she said, "Here's Scott,"
Yeah.
I don't really get a chance to talk to her, But you could just
say,
say,
"No,
I want to talk to you for a little while." Yeah, I'd have to be a little more
That's a great suggestion.
assertive about that.
Yeah. Or, talk to your brother and say, okay, now brother, give the
Give
phone
it
back
to
to
Leslie.
Yeah.
You could always
She'll
send
be
her
delighted.
macadamia nut.
No, that's her job.
Thank you for your comment.
Okay, that's enough.
So, I've had a number of things pop in my head during all this conversation, and I'm going to begin by getting a little nerdy because when it comes to the subject of death, there's 2 particular movie quotes I always tend to think about, and one I used at my cousin's funeral last year. So the first one comes from The Exorcist 3, oddly enough, where a priest and a cop are talking about immortality. Cop says, "I want to be immortal." Priest says, "No, you don't. You'll get bored." Cop says, "I have hobbies." Which really speaks to kind of our fear of mortality. But then I think of Lord of the Rings, where there's a discussion, I think it's in Return of the King. One of the hobbits says to the wizard Gandalf, "I'm afraid of death, that this is the end." And the wizard says, "Death's not the end. It's another path in life, one that we all must take." And that is something that, as both sides of my family have dealt with death within the past 5 years, whether it's from COVID, age, whatever, I've had to keep in mind. In the past 5 years, I've lost a great uncle, I've lost a grandfather, I've lost a cousin. So I thought about that a lot. But regarding kind of the grief process, and what was said about, kind of moving on after a loved one passes away. My grandmother on my mom's side, she and my grandfather were married 3 years. He passed away 3 years ago now. And we weren't quite sure how my grandmother would handle it. And she misses my grandfather every day. However, she has done things that she had never wanted to do or thought to do when my grandfather was alive. My aunt and one of my cousins, in fact, took my grandmother at 85 years old to her first ever strip show. It was, and apparently she loved the experience. But she's found other ways to, while still grieving, move on in living her life. Those are a lot of things I can think about when we have these discussions. But even to your point, Susan, of about the pain, it wasn't long after we lost Keith McClendon. I had walked into, I was heading to a meeting, and Susie and Roger talked from the town hall. Roger comes up and gives me a big old hug. Never received a hug from Roger before. But Susie tells me she goes, you know, herself having experience with loss, says one of the most profound things I've tried to keep in mind every single day. It's never going to stop hurting. But the longer you go from it, you will find that it hurts less often. And that's something that I've kept in mind through all these various losses, is that it's never going to stop. But there are times you will discover, oh hey, it's hurting less often.
I know that one of the things during the grief group, the first 1 or 2 or 3 sessions there are so many tears. I keep lots of tissues around. So many tears. And then it's wonderful to be facilitating and get to like the 7th or 8th week, which isn't a whole lot of time. And somebody will say, I laughed. Or somebody will say, I felt guilty at laughing. And then the wonderful conversation happens with the whole group. That's what's the healing part of a group, is that they'll all go, I felt that way too. Or I thought I was going crazy because I can't watch. So there are things to say. It never goes away. But it stops hurting so much. Thank you for that.
Yes, thank you for sharing your personal story. And so when we experience death in our lives, when we see our friends pass away, when we experience how our family members pass away, how does that shape our views on death and dying, and maybe our preferences or thoughts about what we would want for ourselves? Has that been something that anyone has experienced or wants to share? Yeah, please.
I lost my husband 8 years ago from sepsis after surgery, so it wasn't expected to. But we tried for 3 months to get him so he could get home and be better, and that was part of, you're wishing that it's going to change. But it's hard. It is really hard to let go and experience. It's like PTSD. You go through the process, and then when you get out of that, you think, I don't want that. I'm not going that way. I just, like, I don't want it. If I find cancer, then I'm going to live it out. I mean, I'm 81 years old, and I've had a wonderful life. I was lucky to have my husband, but your life goes kind of like this. And being 81, there are things I can do that I couldn't do anymore. But you do worry about your family and how much your health is going to affect them in their lives, because they're going through good things in their lives and bad things and sicknesses and everything else. And I'm lucky that I live in a log house in the country with a creek down below, and I can mow still, and I can carry wood, and nature is what I love. And so if I fall in a hole, my sister calls from South Dakota, and she'll say, Pat, do you have your phone with you? And I said, it doesn't matter. I mean, if I fall in the hole, and what a way to go. But I don't know. I'm just not afraid of death anymore. I just know I don't want to go to the hospital in Cooter Valley Hospital and go through what, trying to save him, And we had talked about it all, right when you're with it. And it's actually the moment and deciding what you're doing. And he did it. He did go to hospice and was there for 4 days and then was gone. So, but one thing get me the hell out of here. He wanted to die at home, but we just couldn't get him there because he was immobile then and everything. So.
Thank you so much for sharing your experience. I think you touched on some really good points. One is that, what we think about and we plan and we talk about things can look very different from, when it's actually happening. And so I do think that the more we talk about it, the more that people know, the more that we push our physicians to be realistic with us, because the health system is going to offer you more and more and more. But being in a situation that's unexpected, it is an added layer of complexity, because you really do hope that things are going to turn around and you're going to regain your function and your quality of life. But we need to be checking in with our doctors to say, really, are we on this path where he's going to come back home and be outside chopping wood again, or is this looking like we're headed towards the end of his journey on this earth? So thank you for sharing that. And then I also appreciated that you shared about you falling in a hole. One, you're amazing at any age to be living your best life, and the fact that you're recognizing, hey, I have everything I need. I feel so blessed. I'm staying active. This is how I want to live my life. We all, I know it sounds crazy, but we want to die healthy. We don't want to be sick. We don't want to be sick. We just all want to fall in a hole. But what you're illuminating is the difference between our autonomy as human beings and the system's preference for safety. And so when you come into, our office and you're with your sister and we're like, oh, we got to get her a med alert button. We got to make sure she has her cell phone on her, right? We're pushing safety. And what you're saying is, hey, you can't bubble wrap me. Life is going to happen. Here are my preferences, my independence, my ability to keep going out, walking to the stream is more important to me than being safe at the kitchen table. And so I think that's another just really huge topic. So thank you so much for sharing that. Oh, sorry, you had a comment.
No, I just was wondering if the advanced directive, or whatever you call it, your sheets up there, isn't that really important?
I read it twice.
I have 2 copies of myself.
Isn't that really important? Because they would, I have it.
Wow, readers over here.
Well,
Yes.
I can't give this away until somebody else
It
gives
just
it away.
seems to be, having gone through hospice with, family members in hospice, and things not being done the way the person wanted it done, it just seems like that's such an important baseline.
Yes, absolutely. And so hopefully everyone's
In case you do get taken to the hospital, that you didn't want to get her
Yes.
somebody might pick you up and take you there.
yeah.
If you don't have it written, leave me in the hole.
Yes. Leave me in the hole. You can write that on the additional instructions down here. So yes, you're right. Having conversations with your family is so important, and completing the documentations. And so we'll go over that in 1 second.
I have a friend in Colorado that was offered the pill at the end of his life, but with no counseling. He opted not to do it. Would you comment about that? Is
Sure.
it legal in Wyoming?
Sure.
What future you see with something like that?
So any medical aid in dying is not legal in Wyoming and may never be. It is in Colorado, and the correct process is very strict on making sure that the person has capacity to make that decision and that there is significant counseling. So I'm sad to hear it was done in such maybe a flippant way with your friend. That is certainly not the intention of these programs, and there's several states where it's legal, but again, not here. So you have to have residency in one of those states to be able to participate in that. It came about when, people who have terminal illnesses decided that they didn't want to see that through to its natural endpoint, and that they wanted to have more control in that process. Like I said, there's very strict requirements for who actually qualifies for that. It's actually a very small percentage of people. So you can't have dementia and say, I don't want to go through the next 5 years of this process and take this pill. But I do really feel that hospice care and hospice services can get at the same thing that people are looking for when they're having those discussions and conversations. Yeah, great question. Was there another? Oh yeah, great.
Like this. Did your wife ever tell you everything?
Okay.
Yeah.
I'm gonna have to leave in a couple minutes for an appointment, so don't be surprised.
Okay, I won't be offended.
Okay.
Yes, sir.
I will.
Yeah, my daughter's an attorney, she's an estate planner, and yeah, she said, it's real important when you get older to have your final plans worked out with the family, even though that doesn't work out sometimes, but she said that it's really helped a lot of her clients, because they feel better about having their estate ready, and, so.
Yes, and attorneys can be so helpful.
Yeah.
Estate planners can be so helpful in getting everyone on the same page, helping people and their family gain that peace of mind. And attorneys can do the medical advance directives too.
Yeah.
It doesn't have to be done by an attorney, so I never want that to be a barrier for people, because sometimes we put off meeting with our attorneys. But these forms can be completed outside of an attorney's office. I'll have patients come talk to me and say, oh yeah, I did that with my attorney. Well, I don't have a copy of it. And you're not going to your attorney's office when you get sick.
Yeah.
So if you have done this with your attorney already, please do make sure that your medical provider and the hospital, any hospital in the vicinity that you might end up in, does have copies of these documents.
And this is what you put on your refrigerator.
So can I take a minute to kind of go over these forms?
What that was initially.
Okay. So there's two documents here. One is a simple advance directive, and like I said, this just has Ivinson's branding on it, but they're all asking the same questions. It's just, this is a nice kind of concise form, so you guys can pick these up if you would like. The first component of the advance directive is the medical power of attorney. So who you would want to make medical decisions on your behalf if you were unable to. And so I always recommend a first person and a second person. So a primary person and a backup person. And so if you don't have this done, nothing's on file. Wyoming is a next of kin state. So the decision-making power would go to your children all together first, or siblings, parents. So there's a whole line right there. So I also see advanced directives where it's really nice, where all the kids have power of attorney, like all 7 of them. And don't do that. Don't set anyone up like that. Like, your kids are not going to be offended if you choose one to be in this role and you don't lump them all together. So that's torture for all of your children and for the health professionals that need to facilitate things. So I always recommend a primary and a secondary.
Can you get somebody outside the next of kin?
Oh, absolutely. You can put, if you have this done, you can list anyone you want. Kind of guidelines for picking a medical power of attorney, someone who knows you very well, someone who you're comfortable having these conversations with, and someone who you know would uphold your decisions in a difficult time, that wouldn't make their own decisions for you, okay? And then there's some other questions about, if 2 doctors say you're gonna pass away in a short period of time, do you want that process to be prolonged or not? And of course, that's the dying process. It's listed as choose to prolong life, choose not to prolong life, but that's really prolonging death. We oftentimes don't have that crystal ball though. But most people say, no, if I'm dying, I don't want that to be prolonged. The Wyoming POLST form is very, very important. So this is Wyoming's legal document for end-of-life care orders. It's an added layer of protection for your autonomy and asks questions in a different way from your advance directive. So I do recommend both. So you fill this out with your provider. They are able to say, hey, this person has capacity to make these decisions. It's consistent with their goals and values. I'm going to sign this. And the hope is that if something happens to you, you're having pain, I want you to feel comfortable calling emergency personnel. If you pass away before they get there, the hope is that they see this on your fridge and that they don't do something to your body that you wouldn't want, or they do something that you would want, okay? So the questions and the context is very, very important. The context of the first question is when you have no pulse and you're not breathing. Now for most people, especially at a certain age, that means you've had a natural passing. And you would have the opportunity to say, I would like an attempt at resuscitation, which is the default in our country, not in every country. Or I've had a natural passing, take care of my body, take care of my family, okay? It's very important to know if you would like that attempt at resuscitation, what all of the potential outcomes are from that, and that you be willing to accept those potential outcomes. So very different from if, Stephanie's resuscitated versus her grandmother being resuscitated, okay? And the potential outcomes. It never looks like it does on television. So please do keep that in mind and make sure you have a good understanding of that when you discuss it with your provider. The next section talks about when you do have a pulse and or you're breathing, but potentially very sick, how would you want to be treated? So there's full treatment, selective treatment, and comfort focused. Selective treatment is where most people land. That says, hey, if I get really sick, it's okay. Bring me to the hospital, give me medicine, IVs, oxygen, monitor my heart. Do everything you can to try to get me better. But if with all of that, I still cannot breathe on my own, I don't want a tube down my throat and to be on a machine to breathe for me, okay? Full treatment would include the intubation and intensive care. Comfort-focused treatment is really for people who are have goals that are consistent with hospice or very hospital adverse that say, hey, I know it may or may not be treatable, curable, but with whatever time I have left, I want to be at home. And I don't want to spend my days in and out of the hospital, okay? I want to focus on my comfort above all else versus my longevity, okay? And then there's some questions about artificial nutrition. So I recommend, if you have not taken a look at this form, to pick one up on your way out and think about it and continue these
I'm
conversations.
sorry that I have so many questions, but I'm close to that. But anyway, is this a legal document and it can be put on your chart?
Mm-hmm.
Because I've had experience with this, not in Wyoming, but in a different state. And the lawyer had the information, and so the patient goes off into the hospital and you have no documentation.
Mm-hmm. Yes. And so the advance directive is either notarized or witnessed. And then that is a legal document. The Wyoming POLST form is a provider's order. And so it should be taken as a provider's order. Now, we like to think that everyone is going to acknowledge and have and respect our written wishes. But like I said, it is very important that your family understands these forms and your preferences so that they can also advocate in support of these. Because it's going to be very difficult for the emergency room provider to see what the form says, but then have your child screaming at them to, do X, Y, Z. So,
On the subject of never looks like it does on television. And I'm sure all three of you probably shake your heads at Chicago Med. So as we're talking legally binding documents, just to be clear, if I have DNR tattooed on my chest, that is not a legally binding document, correct?
it's not. I mean, I don't discourage it, but it's not legal. There are, if you're wanting something on your person, there are Wyoming pulse bracelets that you can provide, that you can order as well. Again, it's a guidance. Is it a legal thing? Everyone's going to be protected by the Good Samaritan law. We just do, the best we can in the situation. But the people you hang out with should know your preferences, your neighbors, your friends, co-workers, so that, if something does happen, they can advocate and say, look at his chest, it says DNR. His doctor's signature is below it.
Might be his girlfriend's name.
So years ago, I worked for Hospice of Laramie as a CNA and an administrative assistant, and it was for kind of a selfish reason. I wanted to become comfortable with death and understand death, so I wasn't afraid of it. I read Elizabeth Kubler-Ross's books, and she was an early pioneer in all of this, in dying. And I just want to give a kudo out to all the hospice nurses. They were the most compassionate, caring people, helping people die without pain and with dignity. And I just want to give a big shout out to all of you. You're wonderful.
Well, thank you for your work in hospice, and I think that's very commendable to say, hey, I'm uncomfortable with this, so I'm going to immerse myself in it. Not like what Susan did.
Yeah. No.
On the hospice thing, I was talking to somebody in town here, and she wanted to come to this today, but we had talked at a different meeting, and she said that she has experienced being responsible for a dying person twice with her father, and they were her mother and a brother who died young, and they were in hospice in both situations, and they really didn't get any information on what to expect, because they knew they might be alone when it happened. Didn't know what the symptoms would look like, not the breathing, all those kinds of things. And in her telling me about it, she was very anxious still, wishing she had more information.
Yeah, that's unfortunate because I give a whole booklet on an array of different things that you can expect and encourage the families to read it and talk to them about it and ask questions. And we talk about death and dying the entire time they hang out with me.
Yeah.
Because that's what I'm there for, and it's
But that's also why it's good when people go on hospice sooner rather than later. And so we always want to have more time in that comfort, preparation, planning.
Yeah, definitely. So education is huge, and don't be afraid to talk about death and dying. It's so natural, but everybody's so afraid, and I think it is just a cultural thing that has changed over the years. So hopefully more people will start talking about it and start planning how they want to celebrate it. Yes, sir.
My experience of older aging has been of increasing restrictions to what I can do. And for a doer, that's upsetting, difficult to deal with. But also it occurred to me that if there's less I can do, and there's only so much reading and TV you can watch, that it's also an opportunity to do a lot of internal stuff, meditating, and it's an opportunity to get to know who the doer really is at a deep level.
Yeah, that's fantastic. Thank you for sharing that. And There are so many challenges that come up as people age, and the people who seem to be happier are the ones who are pivoting and say, okay, well, I can't do it like I used to, but I can still do this, or it might take me 2 days instead of 2 hours, but I can still get out and be engaged, right?
And climb a ladder to pick, he has an apple orchard.
Oh my gosh, you're gonna give me a heart attack? Yeah, this is like the same.
What are you doing?
Now I want to bubble wrap you. But that's great, that more intrinsic thought. And there's amazing legacy programs that you can like reflect on your whole life's journey and document that for your family. And I think that that can be a really powerful experience as well. Sorry.
Yeah, it's something that I don't know that there's much evidence out there, but there is such a thing as preemptive grieving. For instance, I myself am going through a grieving process that my mother has no idea about. We're preparing for her death, right? In some conversations. And so all of us are preemptively in relationships with individuals about all kinds of situations. Retirement, losses of job, growth, development, loss of function. And again, I think it comes down to where our society doesn't encourage us to talk, to get into groups. These people that are here are the people that are proactive in life. There's a whole set of individuals that are outside of this room that are in bed because they can't, they're sick, they're dying, they're progressing towards. And all of us have relationships with individuals that are in processes of development towards the end of life. You know, we're all worried about, you know, well, what's my next job going to be and what's my next recreational activity? And we don't sit down and we have real conversations about things that, those things matter, but towards death. We don't talk about death, which is a huge impact in people's lives. And the process of going to that. You know, I like this gentleman's statement about we need to look at the legal aspects. We need to look at the healthcare aspects. How about our social, our cash flow? You know, our society hasn't prepared us. And maybe it's not our society's responsibility, but it's each other's responsibility for us to become better.
I'm going to drag her out of here. I'm going to have her Another blip that I was thinking about, what about our ministerial group? Do they put out efforts to take care of us old folks?
I don't know.
See,
I don't know them all. I do know that in my denomination, we as a priest, I am required to have one sermon a year at least where this is the topic.
Well, sometimes we fear. And when Bill was sick, I called her, and what comfort it is. And you should have it throughout. You know, you don't just, when they're dead, then we call you. Well,
but I like Tammy's, you know, Tammy's point of like, maybe it's our responsibility. You know, how do we engage with our friends who aren't here today? Who are maybe, you know, in their lazy boys, flipping through the channels. You know, how do we have a conversation with them about are you living your best life? What do you need to work towards to have a good day?
How many of us would do that though? We're fearful, stepping on toes, and just because we're doing fine, we want the whole world to be fine. And so if I go over to you and say, hey, let's talk about your funeral, let's talk about I'm not gonna be very, thanks a lot, I gotta go
We
to
have
another.
this kind of a conversation in another venue, because I have to leave. But, to have open conversations, we're having these kind of topics, bring people in that we can start the conversations. Thanks, guys.
We're having a great time.
Hi, everybody.
I think you get out and you volunteer, and so you have a purpose in your life, and you're working toward any